Hi guys, in today's video we're going to discuss pregnancy critical care. So there are many anatomical and physiological changes that happens in a woman's body during pregnancy. So for instance, there are cardiovascular changes. So cardiovascular changes include the increase in blood pressure, increase in blood volume, and increase in stroke volume as well. So there's also the enlargement of the chambers of the heart, as well as the compression of the aorta and the inferior vena cava during the third trimester of pregnancy due to the growing fetus inside the mother's uterus. There are also some pulmonary changes, including the increase in tidal volume, the increase in oxygen consumption, and the increase in respiration rate. At the same time, in pregnant women, we see a decrease in oxygen reserve of the mother and the fetus. We also see a decrease in functional residual capacity, as well as a decrease in the arterial partial pressure of CO2. Gastrointestinal changes in a pregnant woman include the decrease in the esophageal sphincter tone. Pregnant women, they experience nausea and vomiting quite often, as well as dyspepsia, also more commonly known as indigestion. Hematologic changes include dilutional anemia. So this happens because the blood volume increases, but the ratio of red cells to whole blood decreases. So this means that the hematocrit also decreases in pregnant women. We also see an increase in coagulation factors, as well as slight granulocytosis. Granulocytosis means the increase in granulocytes. So granulocytes include eosinophil, basophils, and neutrophils. We may also see thrombocytopenia, which is the decrease in the number of platelets. So in terms of metabolic changes, we see an increase in the glomerular filtration rate. We also see an increase in corticotrophins and cortisol, but we see a decrease in the creatinine levels. Now let's talk about the normal values of different blood components in a pregnant woman. So let's start with hematocrit. So the normal hematocrit levels in a pregnant woman is between 32 to 42%. So hematocrit is basically just the ratio between the volume of red blood cells to the volume of whole blood. So this differs in different age groups. It also differs in different genders. So it's usually higher in males and lower in females. And in pregnancy, hematocrit decreases because of the increase in the plasma volume. This means that the blood is less concentrated with red blood cells. So white blood cells in a pregnant woman is between 5 to 12 microliters. And this actually is higher than the normal values. So in pregnancy, white blood cells increase due to the activation of the mother's immune system because there's a foreign body that's growing inside her. And this is also due to the psychological and physiological stress associated with pregnancy. The arterial pH is between 7.4 to 7.45. And the bicarb is between 17 to 22 milliequivalents per liter. The arterial partial pressure of CO2, as we've already described earlier, it decreases in a pregnant woman to about 25 to 30 millimeters of mercury. And in fact, the partial pressure of CO2 in arterial blood, if it reaches 35 to 40 millimeters of mercury, this might be a sign of an impending respiratory failure in pregnancy. So fibrinogen increases to about 3.79 grams per liter during the third trimester of pregnancy. The coagulation factors also increase. So fibrinogen and the coagulation factors increase because this will prevent the woman from bleeding excessively during birth. Also, glycosuria, or the presence of sugars in the urine, is common in pregnancy. And this is because of the increase in GFR. And the increase in GFR just delivers an overwhelming glucose load into the renal tubules. Now let's talk about the medical emergencies and medical conditions associated with pregnancy. Firstly, let's talk about pre-eclampsia and eclampsia. So pre-eclampsia only happens in pregnant women. Usually the onset is after 20 weeks of gestation. So this is characterized by a new onset hypertension in a woman, as well as proteinuria, or the presence of protein in the urine, which is a sign of kidney damage. This condition can damage other organs in the body, like the liver and the brain. Also, if the pregnant woman with pre-eclampsia develops seizures, especially the generalized clonic-tonic seizure type, then this condition is now called eclampsia. Risk factors include hypertension, obesity, and family history of pre-eclampsia or eclampsia. Also, these conditions are most common during the first pregnancies, or in pregnancies with multiple gestations, or if the mother is over the age of 35 years old. Just to quickly go over the pathophysiology of preeclampsia and eclampsia, this usually develops from an abnormal placenta. So what actually happens is that the spiral arteries, or the uteroplacental arteries, they become fibrous and narrowed. This means that there is poor perfusion to the placenta. The hypoperfused placenta then releases pro-inflammatory proteins that then circulate in the mother's bloodstream. And when these pro-inflammatory proteins reaches the endothelial cells that lines the blood vessels of the mother, what they do is they induce vasoconstriction. So the vasoconstriction of blood vessels then increases the mother's blood pressure. Also, when these pro-inflammatory proteins reaches the kidneys, what they do is that they just make the kidneys retain more salt. And when the kidneys retain more salt, this then also increases the blood pressure. So in patients with preeclampsia, usually the systolic blood pressure is over 140, so equal to or over 140. The diastolic blood pressure is greater than or equal to 90. And in extreme preeclampsia, the systolic blood pressure is greater than or equal to 160, and the diastolic blood pressure is greater than or equal to 100. And these extreme blood pressures may induce hemorrhagic stroke as well as placental abruption. So the pro-inflammatory proteins that I was talking about, they may also cause local vasospasm. So this means that they can decrease blood flow to particular areas or organs in the body. So for instance, they could decrease blood flow to the kidneys. And when they decrease the blood flow to the kidneys, then this results to glomerular damage, meaning that the nephrons, so the functional units of the kidneys, can't perform their function so well. So this actually explains why patients with preeclampsia and eclampsia show signs of oliguria, so decrease in the urine output, as well as proteinuria, which is the presence of proteins in the urine. So proteinuria is a sign of kidney damage. These inflammatory proteins can also decrease the blood flow to the retina, causing symptoms like flashing lights, blurred vision, and scotomas. So these pro-inflammatory proteins can also affect blood supply to the liver. And when this happens, this will result to the increase of liver enzymes, as well as the swelling of the liver. And this might actually cause right upper quadrant or epigastric pain in the pregnant women, which is actually a classic sign or symptom of preeclampsia. Endothelial cell injury also causes the formation of lots of tiny thrombi in the vasculature, and the formation of lots of these blood clots in our vessels uses a lot of platelets. So we can imagine these thrombi, or these blood clots, as giant boulders, in the middle of a fast-flowing river. So over time, our red blood cells that are just happily flowing along will bump and smash into these giant thrombi, these giant boulders or obstructions in the way, leading to hemolysis. And these series of events that I've just described actually explain the HELP symptoms that we see in 10 to 20% of patients with preeclampsia or eclampsia. So just to go over the HELP syndrome really quickly, so H stands for hemolysis, E and L stands for elevated liver enzymes, and then L and P, so I can't spell, so it's HELLP, L and P stands for low platelets. Finally, endothelial injury also increases the permeability of the vessels. So this leads to edema. So for example, just generalized edema like the edema, the swelling of the face, hands and feet. Edema can also happen in the lungs. So patients with pre-eclampsia might complain of shortness of breath and coughing. And finally, and probably the most dangerous one, it might cause cerebral edema. And this may explain symptoms such as headaches, confusions, and even seizures, especially in the case of eclampsia. So in terms of treatment, treatments include obviously the delivery of the baby or the placenta, since this stems from the development of an abnormal placenta. But again, it depends on the gestational age of the fetus. And treatments can also include just the management of the symptoms. So for example, the prophylaxis or the treatment of seizures. So this could be IV or IM magnesium sulfate. Also, we can control the blood pressure. So we can use blood pressure medications that are safe in pregnancy, such as hydralazine, for instance. So another problem that we might encounter in pregnant women is postpartum hemorrhage. So postpartum hemorrhage simply means the significant loss of blood after giving birth. Some of the causes may include uterine atony, trauma to the genital tract, so genital tract lacerations, and pelvic hematomas. Treatment may include fluid resuscitation and surgery to fix the problem if it's lacerations, for example, as well as the transfusion of blood products. Another problem or medical condition that may arise during pregnancy are thromboembolic diseases. So we can diagnose these using an ultrasound scan, so Doppler ultrasound scan, VQ scanning, but the most effective one would be spiral CT. Treatments include low molecular weight heparin or unfractionated heparin. We avoid warfarin because warfarin is teratogenic, so it's going to be harmful for the fetus. So this might actually induce neonatal death or spontaneous abortion. We may also encounter postpartum cardiomyopathies. So these typically start at the last month of gestation or 5 months postpartum, so between that time frame. Also, the presentation is usually similar to that of heart failure. So the treatment is actually very similar to heart failure management, including inotropic support, fluid management, afterload reduction. So the next problem or complication that we might encounter in pregnant women is septic pelvic thrombophlebitis. Try saying that 10 times. So septic pelvic thrombophlebitis. So this is a very rare complication postpartum. So it usually presents with persistent fever and not responding to broad spectrum antibiotics. What happens is the pelvic infection actually causes the thrombogenesis of the ovarian veins. So treatments include empiric antibiotic therapy as well as coagulation for about 3 to 6 months. The next one is amniotic fluid embolism. So this is when the amniotic fluid enters the mother's circulation, causing symptoms like shortness of breath, signs of shock like decreased blood pressure, as well as signs of cardiac failure. Asthma is mentioned in the PowerPoint. So the thing to remember is that with pregnancy, the use of inhaled beta agonists and steroids are actually safe. And the only other thing is that hypercapnia in pregnancy is a sign of respiratory failure. Now let's discuss cardiac arrest in pregnancy. So cardiac arrest in pregnancy can be due to many different factors. So there's actually A to H in the textbook or in the PowerPoint. That kind of enumerates or enlists the different potential causes of cardiac arrest in pregnancy. So A is for anesthetic complications, so problems with the anesthesia, and B is for bleeding. So again, bleeding from I don't know, from DICs or uterine atony, genital tract lacerations, placental abruption. C is for cardiac disease, if there's any underlying cardiac conditions or like an acute MI, and then that might induce cardiac arrest. So where were we? D for drugs, E for embolism. So like what we just spoke about, the amniotic fluid embolism. F is for fever or sepsis, and G is for general non-obstetric causes of cardiac arrest. So that's our H's and our T's. So let's see if I remember. So we have 6 H's and 6 T's. So 6 H's include hypoxia, hypovolemia, hyper and hypokalaemia, hypothermia, and H ions. So that's acidosis. And with our T's, there's also 6. So trauma, tamponade, thrombosis, specifically in the heart, so like an MI, thromboembolism, so thrombosis again, but in the lungs, like a PE, for example, toxins. The last one is tension pneumothorax. H for hypertension. So for instance, pre-eclampsia or eclampsia. Now let's talk about BLS considerations in pregnancy. So the compression rates would be the same, so it would be 100 to 120 per minute. The depth would be the same, so a third of the AP diameter. The hand placement will be the same, but bear in mind that in a pregnant woman, the diaphragm is pushed up because of the baby and the uterus. Also, AED shocks are okay. Pad placements, similar. You could use anterior-posterior or anterior-lateral. We need to be aware of something called aortocaval compression. So this usually happens, most commonly happens during the 3rd trimester of pregnancy. So this is when the uterus compresses the aorta and the inferior vena cava, leading to the decrease in cardiac output and hypotension. So what we do in this case is it's called LUD, or lateral uterine displacement. So that just means that we manually displace the uterus to the left side. We have to be careful not to apply direct downward pressure, because that's just gonna make the problem worse. That's just gonna further compress the aorta and the inferior vena cava. So we just displace it manually to the left side. The last topic of this video is perimortem C-section. So perimortem C-section is performed during the onset of maternal cardiac arrest, or when we are expecting maternal cardiac arrest to happen. So if there's an impending cardiac arrest. So the goal of this is to improve the chance of resuscitating the mother, as well as improve the chance of survival of the fetus. The early delivery can reduce the risk of any neurological damage to the baby. So perimortem C-section has to be performed within 4 to 5 minutes upon the onset of the mother's cardiac arrest.